Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Well, hi, everyone. Welcome to Thinking Thoracic, an STS podcast. I'm one of your hosts, Erin Gillaspie, and it's my absolute pleasure to welcome you. My co-hosts who are here with me today, Hari, Jeff, Jane, and I are so excited to bring you the latest and greatest in thoracic surgery. We are so delighted to be joining you live from the STS here in New Orleans, which is so incredible, and we're especially pleased to have an audience with us today. So thank you guys so much for being here. This is why we get to do this. It's because of all of you. Harry, Jeff, Jane, welcome.
Oh yeah, New Orleans, here we are.
So we're at the STS. It's super, super exciting. Tell me, so far, what has been your favorite part of this meeting? Jane, I'm kicking it off to you first.
Yeah. Well, one thing that's very fun for me is seeing how many students and residents are here. I ran into a couple of students giving presentations, preparing for their presentations tomorrow, having already given their presentations. And even running into old students and residents who have already moved on but are still like a part of our field is an incredible part of the meeting for me.
I love that.
Yeah, same here. In fact, speaking of students, we have students from New Orleans and Maryland and Atlanta and Leesburg in the audience right now. So we're really excited to have you all. And the talks have been fantastic. I really look forward to all the video talks as well. And then there was this amazing session that was just started recently on lung cancer surgery for cardiothoracic surgeons with mixed practice, which big shout out to Erin and Hari for giving a great talk on immunotherapy and also sublunar resection. It was a fantastic session yesterday.
Thanks.
Yeah, this has been amazing here in New Orleans. I enjoy, of course, meeting the students. I enjoy the camaraderie, of course. There's so many friends from around the country. One thing that I like, especially that I liked here, is seeing and hearing about topics that I actually don't do a lot of, like lung transplantation. So kind of going to some of those topics and hearing about that and hearing the latest research that's being done and topics that I don't do a lot about is actually really exciting.
I love that. Well, the meeting has inspired us for our topic today, and we've heard a lot of really incredible talks on lung cancer. And Jeff, thank you for mentioning that session yesterday, because I made a little bit of a bold statement during that session yesterday that surgeons are reclaiming stage 3 and stage 4 lung cancer space. And so that's what we're here to talk about. So one of the big things we're going to really focus on with this session is actually more advanced stage lung cancer, specifically the ones that are historically considered unresectable patients. We're living in an era now that we're operating on patients now for aggressive local control as part of a multimodal regimen. One of the incredible presentations that's actually taking place here at the STS is actually on the North Star trial. So Hari, just to start things off, can you talk just a little bit about the basis of that trial and sort of share some of the thought processes behind it and why that's going to be so important for surgeons to know about?
Sure. So the North Star trial was actually a randomized multi-center phase 2 trial. They looked at patients that had an EGFR mutation and got osimertinib specifically. And they got 6 to 12 weeks of osimertinib, then were randomized to local control versus continued osimertinib. And local control was either radiation or surgery to what they consider the primary site. And I don't want to take the thunder away from the actual presentation, but they did find that there's been a signal there with the benefit of local control for these patients.
Absolutely. And one of the big reasons that they're thinking about even having local control in this space is one of the biggest problems we have, especially with targeted agents, is we know that there's a limited lifespan to how long those are going to potentially work for our patients. We know that tumors are very heterogeneous, mutagenic. Local control ideas that we can keep our targeted agents working longer. And so really the inspiration behind a lot of these talks. So Jeff, a patient comes to your clinic in 2026. What sort of burden of disease are we talking about here that we can even be thinking about local control in the stage 4 setting? What's going through your mind as you're looking at these CT scans?
That's a great question. So for me, if a patient, for example, has just 1 or 2 sites to the brain, I would say maybe maximum 3 sites to the brain, and the primary tumor is otherwise T1 or T2, and there's no nodal disease, then I think that's, obviously with all these cases you want to discuss in a multidisciplinary setting, but I think usually that's just go ahead and consider treatment modality that includes surgery. And so in that case, probably you'd treat the brain met first to avoid symptoms, and then follow that up with about 4 cycles of chemotherapy and immunotherapy, get a set of restaging scans, and then do the lobectomy or whatever operation it is required to remove the tumor. I think it's important to assess for nodal disease upfront, and either through EBUS or through a mediastinoscopy, because probably once you start having N2 disease, the idea of this being truly oligometastatic becomes a little questionable. And although I would say that in this day and age with the advances in immunotherapy, everything should be thought of. So for example, even if you're just looking at stage 4 in general, so the Keynote 024 trial, the one that put immunotherapy on the map for stage 4 disease, for patients with high PD-L1, their 5-year overall survival was 31.9%, which is really high when you think about it compared to traditional numbers. And so I think everything should be considered nowadays in this era. And so even for N2 disease, I think that needs to be discussed in multidisciplinary fashion. I think if it's bulky N2 disease, probably that's still too much for consideration of surgery. But if it's a single station, if it's not enlarged, not bulky, and seems to respond to chemoimmunotherapy, I think I would consider surgery. That's for the non-biomarker positive land. If you're, and I know Hari and Jane have a lot of experience in this, but if you're looking at biomarker positive lung cancer, I think that you might consider being even more aggressive. So I was talking to one of my friends who is a Taiwanese surgeon, Mengwei Lin, a very busy surgeon at National Taiwan University. And he was telling me that he had a patient, which he allowed me to share with everybody, where the patient had N2 disease, it had a left upper lobe tumor, N2 disease, and also N3 disease, and disease that went to the serratus on the contralateral side, so M1B. And so they did 3 months of osimertinib, and then did restaging. The tumor shrunk a little bit, and then he actually did a left upper lobe trisegmentectomy, and then that was 9 years ago. Patient's still alive right now. So I think that this is a really exciting time to think about the different possibilities with local consolidative treatment with surgery.
I agree. It sort of feels like we're throwing the kind of oligometastatic rule book out the window. Jane, how about in your practice? What are you do you have hard and fast rules? Is it multi-tumor, tumor board discussion, multidisciplinary group making decisions? How are you handling that in your practice?
Always a multidisciplinary discussion. Actually, I find more and more now it's not just seeing a patient and then bringing it to the tumor board, but in addition to that, I'm actually referring them to the multiple doctors so that they can really have the benefit of the in-depth discussion with each doctor in each field. I think in my experience, I think for a thoracic surgeon, our only other experience kind of being in a realm where it's not as strictly guided by, data that we're used to for lung cancer is managing sarcomas, for example, 'cause for a thoracic surgeon, that's probably the area where we've had the most experience with metastastectomy. And so trying to at least apply and even that's controversial, right? So even trying to apply sort of our basic concepts for that, making sure that, you would only consider local consolidative therapy if you really could treat every site, that you have a plan for local therapy or definitive therapy for every site that's involved. And then obviously to minimize morbidity and maximize, a treatment plan that is easy to tolerate as much as possible. Sometimes that ends up determining which local therapy to go with as well.
Absolutely. Hari, is there a site that's a deal breaker for you? I mean, a patient comes in, are there spots that you're saying, no, this should be a no-go for surgery, but maybe we should consider radiation as an alternative?
To be honest, I don't know if there's a no-go site in this world, especially for with biomarker-driven, all these types of new world of lung cancer. Personally, I want to make sure that they have good systemic treatment, of course, and they have good response to systemic treatment. Personally, I don't know if 6 weeks or 12 weeks is enough. Maybe you need 3 months or 6 months. That being said, I think local control, getting the tumor out if the primary site might help to decrease the chance of a resistant clone. Maybe radiating a brain met or radiating a spine met is a way to go, or both. If they have brain, spine, and lung, this might be an area, hey, we'll take out the lung, the primary lung that's still there. We'll radiate a PET avid site on the spine, and they've already hopefully gotten maybe brain radiation to help with that potential any symptoms. And so I think this is kind of where we have to go with thinking about this as we're seeing, like you just presented a patient 9 years out, right? So we've had a little series that we looked at 8 patients, and our average of getting them to the OR was like 2 years of systemic treatment. Then we went to the OR, and actually going to the operating room helped our oncologist because we were able to now test the tumor. And they found a new clone, and they can treat them differently. So their systemic treatment changed. Maybe if it's something like osimertinib, EGFR, and all of a sudden you find a small cell transformation, that can change everything about the management of that patient, where maybe getting a biopsy wouldn't have been enough tissue to tell the oncologist that. So I think this is where we as surgeons kind of have to think. And I love what Jane said of thinking about this like we think of metastastectomies for sarcoma, or maybe even those patients that have colorectal mets. This is the way we have to kind of start thinking about it for lung cancer patients.
Yeah, Hari, you bring up a great point. So that patient that I told you about, that patient case, so he got the left upper lobe trisegmentectomy 3 months after the EGFR inhibition, and already they saw some small cell transformation. And so I think that doing surgery can help with those guidelines, can help with those treatment decisions. And I think in general, historically, cytoreductive surgery for stage 4 disease, or surgical debulking, so to speak, that is more in the realm of, for example, metastatic renal cell carcinoma.
Yeah.
And never in the realm of non-small cell lung cancer. But in the era of immunotherapy, there are people who are hypothesizing that it can help. And the reasons why, for example, there's a paper by Goussier et al. In Scientific Reports in 2019 where they looked at mice and also 48 patients and looked at the metabolic tumor volume and found that either the mice or the human patients, if you had lower metabolic tumor volume, then you did better. And so the idea is that with surgery, if you reduce the tumor burden, and also you increase the number of T cells compared to tumor cells, if you reduce the physical barriers to immune cell infiltration, and then also if you reduce the immunosuppressive cytokines out there, like GM-CSF or IL-10 or PGE2, then potentially you get a much better outcome. So that's a little bit of the theory of why to Hari's point, I think a lot can be considered. That said, at Mass General right now, we probably for bone mets consider that more of less of an oligometastatic situation. But I think that every situation is different. But by the way, Erin, you've been asking a lot of questions for us.
Yeah.
What do you do? And what are your thoughts?
I love that. So I actually don't put rules around things anymore because really, truly, the responses we see nowadays are extraordinary. And actually, I'm so glad that Hari brought up the piece of time, because time, I feel like, is such a moving target for this. We have time that's used for the purposes of clinical trials, right? And we do that best based on often small phase 2 experiences. In the metastatic space, we extrapolate it to early. So a lot of these trials coming out are looking at operating after 6 to 12 weeks of stability. But the reality is I see a huge number of patients in my clinic who are 6 months out, a year out, 2 years out, who have single site residual disease, where they're looking for opportunities to maybe come off the systemic therapy because of new side effects that they're dealing with, or a new spot has popped up, right? So we have oligo progression, and we're looking for additional information to help guide treatment, to your point, because we can have transformation. One of the very, very first patients I operated on, and actually he is now 10 years out. He was a patient who had an ALK mutation. He had single site residual disease. We operated on him. A year later, so I have a patient who's 9 years out. He had a MET exon 14 mutation. I met him 4 years after his diagnosis. He had bone mets. He had residual disease in his lungs. We actually staged his procedures. We did first resection of his bony mets. 6 weeks later, we did resection of his lung mets. He was able to come off therapy, and he remains disease-free. So I think we're in an era where we really need to start thinking creatively about how we are putting these treatments together, taking patient fitness, taking the different local treatment modalities that we have to creatively treat these patients. So I'm going to be honest with you. I think I have personally sort of thrown that oligometastatic rule book out the window, and we as a group at my institution are making decisions together in our tumor boards. And this is where you have to start inviting new friends to tumor board, guys. Our orthopedic surgeons are coming to our tumor boards if we need to talk about lung cancer with mets to the bones.
Yeah, that's a great point. By the way, fantastic insights, and thanks for sharing. It is interesting that if you look at these clinical trials, for example, North Star, or there's another one by UT Southwestern and City of Hope, phase 2 that was published recently.
Yeah.
And you look at the number of metastatic sites, and actually in those 2 trials, the majority were greater than 3 metastatic sites. And so at least certainly for the clinical trials, people are really pushing the envelope for what is considered eligibility for local consolidated treatment.
Yeah, absolutely.
One thing I think we kind of don't really talk about, well, 2 things I'll say. One is we've also gotten better at surgery. Right?
Yeah.
We were thinking about surgery in stage 4, talking about big open thoracotomies, these types of things. Now we can just do that minimally invasive. And in this setting, we don't even know what the right surgery should be. Like, do we even care if nodes? Should we take nodes? Should we just do a quick wedge resection, get out? I think this is stuff that we can now bring into the space as surgeons. And second, I think, especially with the mutation-driven cancers, I don't know if we have to think about sites of disease for oligometastasis, or do we think about different clones of the cancer as oligometastasis?
Yeah.
I think these are kind of different ways we have to start thinking about this. And like I said, I think we do better surgery. We do minimally invasive surgery, robotic, VATS, so we can get people out back onto their treatments very quickly.
I think it's really interesting how you were also bringing up how there may be more roles than consolidative therapy for surgery for these patients. So, for example, for the melanoma patients who have metastases, more and more frequently we're being asked to, do a wedge resection or something to get a nodule to create, harvest lymphocytes for TIL therapy and vaccine therapies and things like that. And I assume that those indications will only increase. But the one other scenario is that in all of these trials, one of the requirements to move forward with a metastasectomy or local consolidative therapy is that they have a good response to the therapy. But what about the referral where it's like, oh, they had a great response to everything, but now either one spot is not responding and is progressing, or a new lymph node has popped up. It's in a bad location that would require a major surgery. How do you approach that kind of case?
You know what? I actually, those make me excited in one weird way. So we have disease stability overall, right? So we have one bad actor where if we go aggressively to take care of that, whether it's by surgery or radiation, right? Because we have two treatments in our back pocket, we might be able to otherwise keep the patient on the same therapy for longer, especially we have a limited lines of treatments for some of these things, right? We only have so many drugs right now. New drugs are being developed constantly, which is so exciting. So we have more and more treatments for our patients, but we need to buy them time for drug development. We want to keep them on these treatments as long as possible. So for me, I'm seeing that patient going, hey, we have a tool where we can maybe help you to stay on this same treatment longer by taking out the spot that's misbehaving.
Yeah.
And so if it's a hideous surgery where I think it's going to potentially impede their ability to continue, that's where radiation is super helpful. We get a biopsy, we prove that it's progressing, it's a site of disease, it's not a response to therapy, because we all know those lymph nodes can get big on immunotherapy, and that's a good thing. But how about you, Jeff? How about you, Hari? What do you guys think about that?
Yeah, I think that's a great point that you raised. So if it's a scenario where, let's say somebody was on osimertinib, stage 4, multiple sites of metastases, and then was on osimertinib for 2 years, and then has only one site left, primary tumor, but now it's increasing slowly in size, it's becoming more FDG avid. I think I would probably consider, again, in a multidisciplinary setting, surgery as an option in getting it out. I think that if it is in the format where it's more like the clinical trial setting, so in the real world, but like if it follows more of that timeline of a clinical trial setting where you say you want to give osimertinib for biomarker positive lung cancer or chemo IO for non-biomarker positive lung cancer, you give it about 4 cycles or 3 or 4 months and it's still progressing. After that, I probably lean towards not surgery in that scenario. But I think it depends on the patient as well, but that's probably where I would lean towards.
Yeah, I think it's very individualized for the patient, of course. That being said, especially in the EGFR TKI osimertinib setting, I believe in the setting of oligoprogression, you have to worry about small cell transformation. And I think there can be sites where it's hard to get a biopsy, whether that's through IR or through an ion bronchoscopy or an EBUS. It can be very difficult to get a biopsy. Or let's say the biopsy comes back and it still shows adenocarcinoma or atypical cells. I think for us to go in, remove it, can be helpful both from we remove it, but we also now know, we can find out, hey, is there small cell transformation? And that actually could totally change the treatment of that patient. Now they're going to go to a small cell regimen. So I think we have to think about that from, especially the biology of the disease, especially now we understand in the EGFR TKI setting, and maybe we'll learn more about the ALK inhibitor setting, the ROS1, right? So we're going to learn more, especially in these mutation-driven lung cancer space. I think the non-mutation or non-driver mutation lung cancer space is different, right? You're on immunotherapy, so maybe this could help. Maybe radiation could help, but then you have to worry about pneumonitis, right? So these are things that we have to think about in a multidisciplinary fashion for these patients.
One thing for me that I like to think about in that scenario also is whether or not it is progression of something that was known or if it is brand new. Because, in terms of like not wanting to lose your effective therapy, I totally feel that you should go with your local therapy for something that was already there and is clearly just the only thing not responding. But in the scenario where it's a brand new lesion, like something that popped up, much more concerned about, is this just like the beginning and of like 20 lesions in 3 months or something like that. So in those cases, I'm actually more hesitant to pursue local therapy, and then usually we'll talk to the medical oncologist about whether or not it is the right time to move on to another therapy.
All right, you guys, I'm going to switch gears just a tiny little bit because this is a surgical podcast, and y'all, we have talked a lot about drug therapies. Everybody probably at this point thinks we've changed careers into medical oncology. Let's talk about the surgical considerations in this space, right? Because there are some complexities to the decision making. So let's say we have a patient, they have multiple sites of disease, but they've had an incredible response. We now have to address 2 spots, okay? And let's say, for the sake of argument, we've got an adrenal and we've got a lung, right? How are you tackling that? Who goes first? How are you staging? Are you doing things at the same time? Are you doing 2 separate surgeries? Are you spacing them out a significant amount? What are you thinking with regards to that? Jane, I'm going to throw this one to you, and then I'm going to see what the whole gang thinks.
Yeah, I think it really depends on the situation for sure, because, a really healthy patient who might be able to tolerate 2 surgeries in one sitting. Of course, it would depend on what surgeries you're doing, but as long as it would be safe to do at the same time, I think that's always ideal, because then the time off of therapy is going to be minimized overall. So I think when it's reasonable, I would. But if you're going to do a major surgery like a pneumonectomy or something like that, where you have to really control the sort of peri-op issues around that, like, the patient can't get too much IV fluids, all those kinds of things. You can't risk having an adrenalectomy at the same time, and then they have massive bleeding, need major, transfusions or resuscitation or something like that. So it really would depend on the operations, and also what therapy they're on. Because if it's a therapy where there's no long time to hold it before or after surgery, then I might be more lenient in those cases as well.
I love that. How about you, Jeff?
Yeah, I agree. I think that it does depend on the situation, but in general, probably, especially with advances in radiation, it's probably less of a factor of the timing. So I guess what I mean by that is, if it's metastasized to the adrenal gland, we've had situations where adrenalectomy during the same time as the lung operation, or even just radiation, seems to do really well for the adrenal, and then also with the brain mets. Going back to that theme of surgery, I think it is remarkable that the outcomes of the surgical outcomes of these patients in the trials, for example, for North Star, no perioperative mortality, 0%, which is great. And then also, there was a study in Taiwan where they looked at salvage resection after extended treatment with osimertinib, also 0% 30-day mortality. Hari, he has an impressive series where he does a lot of minimally invasive surgery. In fact, I think most of his stage 4s are all minimally invasive. But in North Star, most of them were thoracotomies, and still 0% 30-day mortality. So I think that the innovations and advances in surgery have come a long way.
Absolutely.
Yeah, I think we got to pat ourselves on the back as surgeons, to be honest. You bring up an excellent point. Like 0% mortality in the stage 4 setting. That's that's crazy to think about when you just take a step back and you think about it. So, yeah, I think kudos to the researchers in this study that put this on. I think that's great, and we have to be willing to do this. I think we can do it minimally invasive, and it can give us a lot of input. I think doing multiple sites at the same time for the right patient, it can make a lot of sense, because like what Jane was saying, it minimizes time off of treatment. You can get them back on pretty quickly. But I think that has to be really individualized. And then we have radiation in our back pocket always, which is a great adjunct. If, let's say, a patient does have a complication, God forbid, then we can at least radiate the site later, potentially.
I just thought of another thing related to what you were talking about, though. Wouldn't it be so great now that we have so many options for like perioperative systemic therapy? It used to be it was like always chemotherapy, and everyone knows you wait like about 4 weeks afterwards for the patient to recover. Mm-hmm. But how long are you guys waiting? Now that there's so many different treatments, I wish there was like some easy like checkbox or like guideline about like how long you should hold it before and after your surgery, right?
Yeah. I think, Erin, you were talking about a patient you had that had like edema up to the abdomen or something. Like, what did you do?
Yeah, so it can be tricky, right? And so I'm so glad you brought that up, because the side effects of these medications are real, right? When we look at the clinical trials, we know that 92% of people plus are going to have immune-related adverse events if we give immunotherapy. Targeted agents is going to be the same thing. Most of them very, very manageable. Sometimes they have some very difficult side effects to manage. Now, the targeted agents, thankfully, for the most part, don't have as side effects problems with wound healing, challenges with, cellular suppression. So they're not coming in neutropenic like we can have with challenges with chemotherapy, right? And so actually, for the most part, I don't hold targeted therapies around the time of surgery. I keep them going right up until surgery. I resume them essentially immediately afterwards. Now, if they are having a significant complication from it, I had a patient, literally massive edema up to his nipples. It's a side effect, unfortunately, for some of the tyrosine kinase inhibitors. Some of the MET exon 14 agents have this as a side effect. It can be very difficult to manage. It is not responsive to Lasix at all. It is not related to heart failure. Time off drug fixes that. but also it doesn't lead to increased perioperative complications if you have the right people managing it. And so I think it also speaks to the fact that our teams need to keep expanding to help manage these patients really creatively and carefully in the perioperative setting. So it's not uncommon that I'm talking to my oncologist the week leading up to surgery to make sure we're on the same page. Both of us have seen the patient. We know they're not having side effects that are going to do something to change surgery. I make sure my anesthesiologist knows, please loop them in. They are not as familiar with these drugs. They get really worried about them and the potential side effects. And then we talk again right after surgery. Hey, things went great. We're going to resume right away. And they come see the patients in the hospital with me, which is lovely. So they can make sure that they agree about the timing of resuming treatments. How are you guys handling that? Are your oncologists coming in and helping you to manage these drugs after surgery? Are they giving you feedback live in that moment? How are you guys navigating that?
Yeah, usually just in close collaboration with the medical oncologist. I agree with you. For folks who are on osimertinib or even alectinib and some of those others, I just go straight up. Just don't have them stop unless they have major adverse events that, for example, like you talked about. For chemo IO, I just stick with 6 weeks, just for me personally, just as a break and before surgery. Yeah.
I do about 4 for immunotherapy. It's really interesting. I wonder if 6 makes any difference between the amount of scar tissue for the pathologic complete responders. How torturous are your N1 cases? Jane, how about you? What are your thoughts on this?
Well, I definitely talk with the medical oncologist, and we have like a third discussion too, just to put it into context, because when you have to really rely on someone else's expertise, like you want to make sure they understand where you're coming from also, which is like, well, this is what would happen if they have a wound healing problem and, things like that. So to truly make sure that you're on the same page. For immunotherapy, I love, for at least after surgery, I love for them to start as soon as possible, because I don't know, I just feel like it probably helps in general with even like wound healing stuff. So I mostly worry about like the various targeted therapies, and when we get into targeted therapies that we don't encounter as often. I think the other, because I feel like a lot of us are encountering this in like a lot of our field, not just with cancer, right? Like an explosion of rheumatological options and medications too, right? It's the same thing where you have to really talk to, it's truly becoming like multidisciplinary in so many ways. So I think it's becoming very normal to have those conversations with your medical oncologist. It's also important for them to, know to like check in with you that you've done your post-op check, for example, so that there's an option to change the plan too, depending on what's going on.
So for as soon as possible, is it 4 weeks or?
No, earlier. I tell them whenever you want.
Oh, fantastic. What's the earliest?
For like a checkpoint inhibitor.
Yeah.
For targeted therapy, I usually ask them to wait 3 or 4 weeks. And all depending on my post-op check.
Even for osimertinib, like on EGFR patients?
Yeah, pretty much. I mean, it's just, that's like when I really feel like, oh, we've passed all the obstacles,
Yeah.
Here's the thing. There isn't data in this space yet to really tell us that that's wrong, right?
Yeah.
Like, we're learning this right now.
Yes. But I want to add, even though it's very exciting, it also is uncomfortable. And I think that it is good for it to remain uncomfortable because, we're just dealing with the situation where you don't have all the data, but that doesn't mean that we would prefer to have the evidence. And we do all have to remain really involved and invested to make sure that we're not backing off of, the desire to get more data because it's acceptable-ish right now to make these assumptions.
Yeah. So I think that's a great point. Speaking of data, people have tried to design randomized trials. So some of you may know about the trial by Gomez et al. That was published in Lancet Oncology. And then the long-term follow-up was in Journal of Clinical Oncology. And since then, there's another trial called Ramon. So basically, this is where stage 4 oligometastatic disease, trying to randomize to local consolidated treatment and versus standard of care. That one, unfortunately, did not accrue. And then there's also another one, NRG-LU002, which they did reach their endpoint, but they haven't published their results yet. It has been generally hard to, so I'm part of Alliance, and so we're talking about clinical trial space in this area. And what we have found was that the surgeons, so for example, Brendan Stiles and Mara Antonov, they proposed this wonderful study concept. The surgeons seem more excited than the medical oncologists. And I think we're gonna have to see if we can get our medical oncologists just as excited about these kind of trials, because it's important. Because for example, for North Star, the median progression-free survival, I think, was 25 months, which was really good.
Yeah.
It's 8 months more than the than the Gomez et al. Trial. So I think that there's a lot of, and then also nowadays so even with Gomez et al., like if you look at their accrual, it was a much older set. So older surgical techniques and things like that. So, but we're gonna have to, I guess, just continue to work on getting a lot more enthusiasm from everybody on that.
You know what? I'm so glad you bring that up, because actually one of the biggest problems we've had with a lot of clinical trials over the last 5 years is they've closed due to low accrual. And a lot of that, unfortunately, has been a problem with surgeons sending their patients in for consideration of important trials like this. And so I think this is a big call to action, that we need to be thinking about clinical trials for our patients all the time across the entire spectrum of disease, from stage 1 all the way through stage 4, and making sure we're part of these conversations. So we're making sure that we can deliver these unbelievable outcomes, right? Prolonging our progression-free survival, which is so critical for our stage 4 patients, but also making sure we're meticulously integrating surgery and that we're answering questions meaningfully. If we don't make these trials, other people make these trials, and we might not be able to answer questions in the way that we expect. I mean, look at the impact of INT 0139. We're 25 years later before we can say, yeah, guys, N2 nodes are actually ours. It took 25 years, right? And we got an answer to a question in a way that didn't make sense from that trial. So I think that it's really, really important. I'm so glad you brought that up, Jeff, because that's such a critical part of what we do as surgeons. All right, you guys, lightning rounds. This has been an incredible discussion. I'm just so excited and buzzing about everything you guys have talked about. What is one closing thought that you want to leave our audience with today? So I'm going to just go down the line. Jane, I'm going to start with you. What do you want people to take home from this complex space that we've been talking about?
That there's so much more to learn, and I would say, especially because there's so many trainees here in this audience today, like these are all things that like you could have a huge part in.
You guys, thank you so much for another incredible podcast. How fun it is to get to hang out all together. We should do this more often.
And in New Orleans, we should get some beignets or something.
Done. We'll do the next episode at Cafe Beignet. All right. Well, thank you guys so much for joining us today. Wishing all of our incredible listeners a wonderful rest of the day. Thank you so much for being with us. Please continue all the incredible, inspiring work that you do. Please keep educating people about lung cancer and the importance of screening. Keep taking extraordinary care of patients. And as always, keep smiling. To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.